Good morning. We have with us Professor Pradeep Bhattacharya, who is the professor in critical care, RIMS Ranchi, and also the president of ISCCM. We welcome you to the Natco Pharma Specialty Studio, and we look forward to your insights to the young generation of doctors that is associated with critical care, especially in bacterial resistance. Professor, what, as per you, have been the changes that you've foreseen in critical care management?
As far as bacterial resistance, you are asking specifically about bacterial resistance and multi-drug resistant organisms. You see, as far as advancement is concerned, now gone are the days when actually we used to believe so much on cultures, because now we are switching from culture to next generation sequencing. Now people should look after that. Yes, cultures is although it is one of the most highly reliable tool for diagnosis, but in 50% of the cases we do not get anything out of those culture reports. So that is why the concept of this next generation sequencing, that is genomic sequencing, that has come. And I think in future that is going to take over this, because they are fast also, and they give the reports also faster than what we get, as far as the way the time which takes to do a culture, almost same time we can do it, the next generation sequencing. And yeah, the kind of bacteria, if you are asking, because you see, I'm working in a government setup. We, when you talk about use of antibiotics, I'm not very fond of using very high level of antibiotics immediately. Currently, if you see, the highest antibiotic which we are using in our institute is meropenem. I think as far as use of new antibiotics, like which are available in India, like ceftazidime, avibactam, and ceftaroline is concerned, barely we reach up to that stage, and one case maximum in a month or two case maximum in a month, not more than that. So we feel that resistance pattern, or the laboratory, because we have got a very good supportive microbiology laboratory, whatever we get and whatever the way we treat with the available antibiotics, and if you compare the outcomes which we get as far as recovery of the patients are concerned, it is quite good. So it is not that because of multi-drug resistance the death rate is too high. I always raise this question in forums. Said, have you ever seen that in last 20 years there is any change as far as death is concerned when we talk about multi-drug resistant organisms? The death which used to happen 20 years back is almost same today. There is no change, and there is no data which suggests that the percentage of death has actually changed. So we as human being, we must take care, we must take precautions, we must do our job, and let the bacteria do their own job, because it is, this struggle will never end. This is a continuous struggle. So, and we are also growing, we'll also come with newer and newer antibiotics in future, and bacteria will also change its shape by doing mutations, and they will keep on challenging us. And I think this earth, in this earth, they are the primary living organisms. They have come before us. We have come much late after this bacteria is there in the earth. So I think we should have some friendly relationship with these organisms. So if we develop a good friendly relationship and we change our approach, that by not by killing, by some other means, if we can handle this bacterial load in our body, that will be something which I see that that will actually change our future.
Thank you so much for that detailed explanation, and a lot of wisdom there. What is your advice to the young ICU doctors for them to enhance patient care?
See, the first thing is that um, education, wherever you are working, the teaching and education makes all the difference. Because always I say, what mind knows, only then eyes can see, and then only hands can perform. So knowledge, giving appropriate knowledge and getting appropriate knowledge is not the question of teachers, but it is also um, it is the responsibility of the student to get maximum knowledge from your teacher. So if you have good knowledge, then automatically you will understand what you are supposed to do with these resistant organisms, or what we are talking about, use of antibiotics, antibiotic stewardship, or dealing with antimicrobial resistance. And although we are running many programs, stewardship program for fungus, for bacteria, for so many things, but it will only work if you implement whatever knowledge you have, you implement it on the bedside. You know that hand hygiene is very good, but you are not doing it, you are not practicing it. So then it will not work. You know that stewardship is very good, we must do it, but you are not applying on the bedside, it will not work. So everything, whatever knowledge you gain from your teacher, from your institution, by attending the conferences, you should implement all those on the bedside. Try to implement that. Then only the future is going to change.
Thank you for highlighting the importance of applying the knowledge, so that makes a lot of advice to the younger generation. What is the prevalence of carbapenems in the practice? What treatment options can really work well?
We have this carbapenems you're seeing because it's a hot topic for last, I think, almost 5 years. We talk about KPC, then CREs, then MBLs. A lot of talk is going on. These are there. Obviously, I don't say it is not there. But what I understand, these are preventable. You can get rid of, because now it has become a fashion that as soon as a patient comes inside the ICU, start with meropenem. So if we continue with this fashion, then future is not bright. Future is bad. And you have to understand that there are many basic antibiotics which are equally competent, equally potent if you are appropriately get a knowledge to how to use these antibiotics rather than using meropenem. It will be uh, much more beneficial not only for the patient but also to prevent these CREs and other things. Now, as far as if you have CREs, now I say, as my hospital, we have 60 bedded ICU. We also send everyday culture, 2 3 cultures from almost alternate patients. When we see the growth of CREs and MBLs, it is quite high. It is almost 40 to 50% of these patients grow. But because of some or other reasons, because ours is a government organization, some or other reasons, so many times we fail to change the antibiotic. We just rotate in between carbapenem, penicillins, and cephalosporins. These are the beta-lactams, and we see good outcomes. Now, if you say that CREs, if the patient has developed CREs, we have to use ceftazidime avibactam, you have to use aztreonam, you have to use ceftaroline or whatever. But because of, I say that patient will die if you do not use this thing. I say I don't accept this fact, because death is related to many other things, and many a times, as it is said, that it is not that organism is there and it is a pathogen. So the organism, we see Acinetobacter is there, but it is a colonizer. It doesn't harm the patient. So that is why I'm saying be very judicious while using and taking use of these antibiotics. The first and foremost thing as an intensivist is your clinical acumen. You see the patient clinically. Even if the patient is growing Acinetobacter, even if the patient is growing CRE, look at his clinical condition. If his clinical condition is good, just stop there. Don't go for any further active antibiotic intervention, because that will be harmful for the patient. That may harm and the patient may deteriorate. So you always rely on your clinical uh, strength.
Professor Bhattacharya, we wish you all the best along with ISCCM in everything that you are doing for the healthcare industry. And on behalf of Natco Pharma Specialty, we thank you for your valuable time and sharing all these insights to the young generation of doctors. Thank you so much.